Hello, everyone, and welcome to PodBites, where we break down complex medical topics into bite-sized pieces, perfect for your commute, coffee break, or whenever curiosity calls. I'm Rafah Shaheen, your host for today's episode, and joining me is Reena Nuruddin for a deep dive into one of medicine's most dramatic and life-saving interventions, stem cell transplantation.
Hi everyone, I'm Reena, and today we're covering the complete picture of stem cell transplantation, starting with what it is, moving on to its different types, the step-by-step procedure, and finally concluding with the serious complications that can arise.
Now, it sounds pretty intense, but I think that if we understand the logic behind it, it would make everything click into place. And so let's start with the basics. Firstly, what is stem cell transplantation?
So, stem cell transplantation is a procedure where we intentionally eliminate a patient's diseased bone marrow using chemotherapy and or radiotherapy and then replace it with healthy blood-forming stem cells.
So essentially, what we're doing here is wiping the slate clean and rebuilding the blood system from scratch. But I'm curious, are there sources for these stem cells?
Yes, we have three main sources for stem cells. First, the bone marrow, and this is usually collected from a donor in the operating room. Second, we also have what we call peripheral blood stem cells. These stem cells originate in the bone marrow, but we use medication to move them into the bloodstream and then collect them. Finally, we also have umbilical cord blood stem cells, taken from the placenta and the cord after birth.
Got it. So the source can vary, but the principle is the same. Now, before we get into the procedure itself, I think we need to look into the different types of transplants because they work very differently, if I'm not wrong.
You're right. The types of stem cell transplants are based on who the cells come from. We have autologous, that's when the patient's own stem cells are collected and later returned to them. Allogeneic, when the stem cells come from someone else, which is what we mean when we say donor. And syngeneic, a rare situation where the donor is an identical twin.
And within the allogeneic transplants, you can have different donor types, right?
Exactly. Allogeneic donors can be HLA-matched siblings, and that's always our ideal match. Unrelated HLA-matched volunteers, usually from donor registries, and umbilical cord blood, which is from a bank and does not require perfect matching.
Perfect. I think we've got allogeneic donations down. And to recap, we have matched siblings, unrelated volunteers, and lastly, cord blood. Now, let's switch gears to the other major approach, which is autologous transplantation, where we use the patient's own stem cells.
Exactly, that's right. An autologous transplantation is a completely different strategy. The conditions we use this for are mainly chemotherapy-sensitive cancers, especially multiple myeloma, Hodgkin lymphoma, and many types of non-Hodgkin lymphoma.
So here's a key concept for autologous transplantations. What we do is that we collect the patient's stem cells in advance, then give high-dose chemotherapy that would normally cause irreversible bone marrow failure.
But then we rescue them by infusing their own stem cells back, which come to the bone marrow and start producing blood cells in about 2 weeks.
Exactly. So the stem cell rescue allows us to deliver chemotherapy doses that would otherwise be fatal. So it's all about maximizing tumor kill while preventing permanent marrow damage. Now, allogeneic transplants, we know that they are more complex because you're introducing someone else's immune system into the patient.
Right, and this is used for a wider range of conditions. Malignant indications include acute myeloid leukemia, acute lymphoblastic leukemia, chronic myeloid leukemia, myelodysplasia, lymphomas, and myelofibrosis. Non-malignant indications include aplastic anemia, thalassemia major, sickle cell disease, and inherited immune deficiencies.
And the logic here is different from autologous transplants. You're not just giving high-dose chemo, you're also introducing an entirely new immune system that can attack any remaining cancer cells.
Exactly. The donor immune cells, especially T lymphocytes, can recognize and destroy the recipient's malignant cells. This is called the graft-versus-leukemia, or GVL effect, and it's a huge part of why allogeneic transplants work so well for blood cancers.
But of course, that same immune system can also attack healthy tissues, which is where graft versus host disease comes in. But we'll get to that later. All right, I think we've covered the different types of stem cell transplantation, and it's about time that we go into the actual process. So, Reena, what are the major steps of stem cell transplantation?
So, once we decide the transplant is on the table, the process moves through a clear series of steps. First, we'll start with diagnosis and initial treatment. The goal here is to get the disease into the lowest possible burden.
And by lowest possible burden, you're referring to remission here, right?
Yes, because transplants work best when the illness is already controlled. Next comes the decision point. Is a transplant actually the right strategy for this specific patient at this stage of their disease? That's where the transplant team evaluates risks, benefits, and timing. If the plan is for an allogeneic transplant, we then move into donor identification. We look for the closest possible HLA match, usually a sibling first, then unrelated volunteer registries, and cord blood if needed. After that comes conditioning. This is the intensive part. High dose chemotherapy, sometimes combined with radiation. It serves two purposes: to erase the diseased marrow and to suppress the immune system so the new stem cells can take hold. Then we infuse the stem cells. This part is surprisingly simple. It's given just like a blood transfusion through a central line. The stem cells know exactly where to go. And finally, we support the patient through engraftment. Over the next couple of weeks, the infused stem cells migrate to the bone marrow, settle in, and start producing healthy blood cells. During this phase, patients are very vulnerable, so we manage infections, transfusion needs, and any early complications until the new immune system is up and running.
Okay, I get it, but how do we actually get them, the stem cells?
Remember earlier, we talked about 3 possible sources of stem cells. Now, this is how we actually collect them. The most common method today is peripheral blood stem cell collection. We give the donor several days of GCSF to mobilize stem cells out of the bone marrow and into the bloodstream.
Whoa, what in the world is GCSF?
So, GCSF, or granulocyte colony stimulating factor, is a cytokine or growth factor that stimulates the bone marrow to produce more neutrophils to release into the blood.
So, what do these neutrophils do?
These neutrophils are going to release enzymes like proteases that will break the bonds anchoring stem cells inside the marrow, allowing them to circulate. Once they're circulating, we collect them with an apheresis machine, similar to donating blood, but it filters out the stem cells. The second option is a bone marrow harvest. This is done in the operating room under general anesthesia, where we aspirate marrow directly from the iliac crest. Depending on the patient's needs, we usually collect somewhere between 500 and 1,200 milliliters. The third source is umbilical cord blood. It's taken from the placenta and cord after birth and stored in public cord blood banks. It's rich in stem cells but limited in volume, which is why it's primarily used for children or smaller adolescents.
And how do we know if we've collected enough stem cells?
We check whether we've collected enough by measuring the CD34 positive cell count. That's the surface marker we use to identify true hematopoietic stem cells. For a safe transplant, we usually aim for at least 2 million CD34 positive cells per kilogram of the patient's body weight.
Okay, now we have the stem cells. The next step is conditioning, which, according to what we've said before, is the most intense part.
Right. Conditioning usually involves chemotherapy with or without total body irradiation. The goals are eradicate the malignant disease, suppress the recipient's immune system to prevent rejection of donor cells, and to create space in the bone marrow for the new stem cells to engraft.
And after conditioning, the patient is left with essentially no immune system and no bone marrow function.
Exactly, which is why this next step is so critical.
So after conditioning is complete, we infuse the stem cells, and this is what we call day 0.
Right. The stem cells are given intravenously, and they come to the bone marrow on their own. Then we wait.
And during this waiting period, which lasts about 2 to 3 weeks, the patient is usually in severe pancytopenia, which means no neutrophils, which makes it a high risk of infection, no platelets, which means high risk of bleeding, and lastly, no red cells, which is severe anemia.
Exactly. Patients need intensive supportive care during this period. Prophylactic antibiotics, antivirals, antifungals, blood transfusions, platelet transfusions, and strict isolation in high-efficiency particulate air or HEPA filtered rooms.
And then around 2 to 3 weeks post-infusion, you start seeing the first signs of engraftment.
Right. Monocytes and neutrophils appear first, followed by platelets. Engraftment is officially defined as an absolute neutrophil count greater than or equal to 1,500.
And here's a fascinating detail. In allogeneic transplants, the patient's blood type changes to match the donor's.
Exactly, because the new blood cells are all donor-derived.
Okay, let's move on to the complications of stem cell transplantation, because we know that it is incredibly powerful, but it comes with serious risks. Let's break down the major complications, Reena.
The complications can be grouped into immediate risks during the pancytopenic period, medium-term risks in the first few months, and long-term risks, which occurs years later.
Let's start with the immediate risks. Within those first few weeks, what exactly are we looking at?
There's an increased risk of infections, which include bacterial, fungal, and viral, bleeding due to thrombocytopenia, mucositis, which is painful inflammation of the GI tract, and organ toxicity, including the liver, lung, kidneys, and heart, all from the conditioning regimen.
And among infections, what I know is that CMV is particularly dangerous, right?
Absolutely. CMV is one of the major infections we worry about after transplant. It can reactivate in the recipient or come in through the donor stem cells, and when it flares, it can cause a severe interstitial pneumonitis, the kind that can be fatal if we don't catch it early. That's why we monitor patients so closely and treat them aggressively with antivirals like ganciclovir, valganciclovir, or foscarnet when needed.
Now, once the patients get through the early period, what are the risks in the medium term period?
Once patients make it past the early post-transplant phase, we will still watch closely for a couple of important complications. One is veno-occlusive disease, also called sinusoidal obstruction syndrome. That's when the small veins in the liver get clogged, leading to jaundice, painful hepatomegaly, fluid retention, and sometimes ascites. The other is hemorrhagic cystitis, inflammation and bleeding in the bladder. It can be triggered by certain chemotherapy drugs, especially cyclophosphamide, or by viral reactivation.
And we also have the risk of graft rejection or graft failure, right?
Exactly. If the recipient's immune system isn't fully suppressed, it can reject the donor cells. That's why immunosuppressive medications are so crucial.
So, for patients who survive the transplant and achieve long term remission, what are the late complications?
The main ones are infertility from the conditioning regimen, secondary malignancy, especially if total body irradiation was used, cataracts, also from the irradiation, and post transplant lymphoproliferative disorders, essentially EBV driven lymphomas.
So, there's a trade off, right? We cure one cancer, but then increase the risk of another down the line.
Exactly. But for many patients with otherwise fatal diseases, it's still worth it.
All right, now let's talk about one of the most important complications of allogeneic transplants, which is graft versus host disease or GVHD. What is it?
So, GVHD occurs when donor derived immune cells, especially T lymphocytes, recognize the recipient's tissues as foreign and attack them.
And the risk increases with either older donor or recipient age or degree of HLA mismatch.
Exactly. And to prevent GVHD, patients receive immunosuppressive therapy, usually cyclosporine or tacrolimus plus methotrexate.
But even with prophylaxis, GVHD is still common. And there are two types, right? We have acute and chronic.
Yes, acute GVHD typically shows up within the first 100 days after an allogeneic transplant, and it tends to hit three main organs. First is the skin, which often develops a maculopapular rash that can range from a mild redness to a severe diffuse eruption. Second is the GI tract, where patients develop watery diarrhea, abdominal pain, and sometimes nausea or cramping. And the third is the liver, which shows a classic cholestatic pattern, high bilirubin and alkaline phosphatase with relatively normal AST and ALT.
And that liver pattern is a great clinical tip. It's cholestatic, not hepatocellular.
Exactly. And the treatment here is high-dose steroids.
So, chronic GVHD occurs after 100 days?
Right, chronic GVHD shows up after that 100-day mark, and it can involve multiple organs. Common features include a dry, irritated mouth with lichenoid changes, skin tightening that can resemble scleroderma, dry eyes, and lung involvement like bronchiolitis obliterans. It can also affect the joints with stiffness and the liver with chronic dysfunction.
So, chronic GVHD kind of looks a lot like autoimmune connective tissue disease.
Exactly, like scleroderma or Sjogren syndrome. Treatment is with long-term immunosuppressive therapy.
Now, here's the paradox, right? GVHD is a complication, but it's also associated with better outcomes in leukemia patients. But how?
Because the same donor T cells that attack the recipient's normal tissues also attack any remaining leukemia cells. This is the graft-versus-leukemia GVL effect.
And I've seen studies that show how patients with mild GVHD actually have improved survival compared to those with no GVHD.
Exactly. And patients who receive stem cells from an identical twin where there is no GVL effect have worse disease-free survival than those who receive allogeneic transplants.
So it's a double-edged sword, right? We want some immune reactivity for tumor control, but not so much that it causes severe GVHD. All right, now that we've laid down the fundamentals of stem cell transplantation, let's pull it all together with a few high-yield cases you're guaranteed to see in exams and in the wards.
Here's the first one. A 58-year-old man with newly diagnosed multiple myeloma has a strong partial response to initial chemotherapy. His physician recommends autologous stem cell transplantation. What's the primary rationale behind this approach? Options include A, to provide graft-versus-leukemia effect, B, to allow administration of a high-dose chemotherapy with stem cell rescue. C, to replace the patient's immune system with a donor immune system. And D, to prevent future relapses through immune surveillance.
So the answer here is B, to allow administration of high-dose chemotherapy with stem cell rescue. The goal here is to give myeloablative doses of chemotherapy to deepen the response and potentially achieve complete remission. His own stem cells are collected first, then after a high dose of chemo, they're infused back to rescue the bone marrow.
Exactly, and because it's autologous, there is no risk of GVHD, but also no GVL effect, so options A and D are incorrect. Let's move on to the next case. A 34-year-old woman had an allogeneic stem cell transplant for AML. It's now about 1 month after her transplant, and she suddenly develops a widespread maculopapular rash, watery diarrhea, and new jaundice. Her liver tests show a cholestatic pattern, high bilirubin and alkaline phosphatase, but her AST and ALT are normal. Given the timings and the organs involved, what's the most likely diagnosis? Answer options include A, CMV hepatitis, B, acute graft-versus-host disease, C, veno-occlusive disease, and D, drug-induced liver injury.
So the answer here is B, acute graft-versus-host disease. This is classic acute GVHD, which occurs within the first 100 days. It involves 3 major organs, as we've mentioned: the skin, GI tract, and the liver. Again, the cholestatic liver pattern, elevated bilirubin and alkaline phosphatase with normal transaminases, that is the key clue.
Exactly. CMV hepatitis would show elevated transaminases, and veno-occlusive disease typically presents earlier, within 3 weeks, with hepatomegaly and ascites. To treat this patient, we would give her high-dose steroids. Now, for our last case. A 42-year-old man is about 6 weeks after an allogeneic stem cell transplant. He comes in with fever, a dry cough, and progressive shortness of breath. His oxygen saturation is down to 88% on room air. A chest x-ray shows bilateral interstitial infiltrates, and his labs show elevated LDH with normal neutrophil counts. What's the most appropriate next step? Options include A, start broad-spectrum antibiotics and observe, B, perform bronchoscopy, C, start empiric ganciclovir immediately, and D, increase immunosuppression for possible GVHD.
So the answer here is C. We start empiric ganciclovir immediately. This is highly suspicious for CMV pneumonitis, which we know is a life-threatening complication. In this setting, you do not wait for any confirmatory testing. You start antiviral therapy right away.
Exactly. While bronchoscopy can confirm CMV, the clinical picture is urgent enough to warrant empiric treatment. You can send CMV PCR from blood and proceed with BAL once the patient is stabilized, but treatment shouldn't be delayed.
All right, everyone, let's recap what we've covered today. So we understood the definition and types of stem cell transplants: autologous, allogeneic, and syngeneic. Then the step-by-step procedure, the collection, conditioning, infusion, and the engraftment. Major complications like infections, organ toxicity, VOD, or veno-occlusive disease, and long-term risks. And lastly, we got into the graft-versus-host disease, which is acute versus chronic, and the GVL effect.
Stem cell transplantation is one of the most powerful treatments we have. It's a full reboot of the blood and immune system. It can be life-saving, but it demands the right patient, the right timing, and meticulous supportive care.
And that wraps up today's episode. Thanks for tuning in to PodBites. We hope this episode helped demystify stem cell transplantation and gave you a clear framework for understanding the complexities of this procedure. If this episode helped, send it to a friend, preferably one who's still confused about the difference between autologous and allogeneic transplants.
Stay curious, stay sharp, and we'll see you next time.